Welcome to Speaking of Talking. Hi, I'm Jenni Stack, voice and speech coach and total voice nerd, here to explore all the ways our voices shape how we connect, lead, and show up in the world. Each week, we'll chat with inspiring leaders, speakers, and experts from all kinds of industries, people who use their voices to move audiences, rally teams, and make an impact. From polished political speeches to spontaneous sideline interviews, we'll break down what works, what doesn't, and why it matters. At Jenni Stack Voice and Speech, we've spent the last decade coaching Fortune 500 executives, broadcasters from CNN, ESPN, CBS News, ABC News, and even prepping Hall of Fame speeches for the NFL and Major League Baseball. And now, I get to bring those conversations and insights straight to you. So if you love talking about talking, you're in the right place. And be sure to subscribe to Speaking of Talking wherever you get your podcasts so you don't miss an episode. And check the show notes for helpful tips and tools. I'm so glad you're here. Let's get talking. My guest today is Dr. Jeff Waugh. He's a neurologist at UT Southwestern, specializes in functional neurological disorders. We're going to talk about it as FND just because functional neurological disorders is a tongue twister. But basically, and you expound on this, Jeff, but it's studying why the brain and the nervous system sometimes produce symptoms that don't necessarily have a structural cause. And when it comes to understanding why a voice stops working the way it's supposed to, is exactly why I wanted to talk to you today to understand the underlying mechanics of it. If a laryngologist is looking in there and they don't see anything that is making the voice do what it's doing, what are the other possible explanations? Do you want to tell us a little bit more about where you practice, what you've studied, and what functional neurological disorder entails?
Thank you so much for having me, Jenni. This is a great opportunity to talk about something I really love. Like you mentioned, I'm a pediatric neurologist. I trained as a movement disorders neurologist, so I specialize in the ways that kids move abnormally. Along the way in medical school and residency, I saw lots of people who have what we now recognize as FND. And over time, it was clear that people were not taking good care of these patients. There was a lot of dismissal. There was a lot of even hostility from medical people towards patients. And then there would be not understanding why these people didn't ever get better when the medical teams really weren't caring for them in the way that we would care for other patients. So when I got to a point in my training when I realized like the buck stops here, if I don't get better at this, then I'm going to continue to see patients and not do well. I realized like I got to do it a different way. There has to be a different way to approach these patients. And for me, that transformation was just starting with kindness. That big shocker, being kind to people ends up having a much better result than being mean to people. And that's really kicked off a change in the way that I practice and the way that I approach these patients, but that spills over to other aspects too. I've realized the importance of starting with kindness with all of my patient interactions, not just with FND.
Some of your other patients, what are the other things that you treat?
I specialize in movement disorders. So kids who have tic disorders, tremor, movement disorders like dystonia, cerebral palsy, myoclonus, all of those are my bread and butter.
Gosh, you mentioned hostility directed at these patients sometimes. Yeah. Can you elaborate? What were you seeing?
We wrote a paper a few years ago that collected the experiences of physicians from around the world and many patient testimonials too, that people have seen such bad behavior modeled as the way you are supposed to interact with these patients. So in that paper, I'm happy to pass on the link to that if you like. Yeah. It has a lot of quotes from training physicians, those who are supposed to be showing us how to do things right. And the gist is these people shouldn't be bothering us. They shouldn't be taking up time in our emergency room. They shouldn't be taking a bed that a truly sick person needs. All the while, this is a human being who's suffering and who, in many cases, has a great deal of disability. And the compassion that many physicians will feel naturally towards their patients is somehow left by the wayside when it comes to patients with FND. Now, I don't want to paint with too broad a brush. There are many kind, compassionate physicians who are doing a great job taking care of their FND patients. But as a specialty, the world of medicine has had to kind of come to terms with needing to do better and recognizing that our interaction towards our patients is an essential framing that unless we are willing to be kinder in the outset, we're not going to have good outcomes.
Why do you think that reaction occurs? Is it is it because they're not seeing something structural, so they don't believe that the symptoms are real?
I think that's a part of it. And I think that's how it was taught for many years. The irony is that there are a great many disorders in neurology and in medicine writ large where there's not an overt structural problem, and yet the person has a clear dysfunction. We're very comfortable with that in some other areas. But with this particular area of FND, we've sort of mentally branded it as being, not real, not worthy of attention, time, compassion, and to our patient's detriment.
Can you give a better definition than I did of functional neurological disorder?
So FND is a condition when a person's ability to move or to perceive the world is limited by the information sharing between different brain networks in a way that is not related to an injury or an absence of the capacity. That is, their brains can do the thing, but their brains have, in a lot of ways, forgotten how to do that thing.
I think I first became aware of what you do because I have a client who was dealing with something called muscle tension dysphonia. He had been to see laryngologists. He had worked with voice teachers, of maybe stage voice teachers, singing teachers. When he went to see the laryngologist, everything looked pretty normal. Everything was functioning. There weren't nodules, there weren't polyps. And yet he experienced significant pain after speaking for a number of hours. He would experience kind of a sensation of wetness. It wasn't there all the time. It would come and go, but it was significantly impacting his life, his confidence in his ability to do his job, which involves lots of talking, leading meetings, virtually, in person, a very heavy talking load. And because he couldn't get any relief, he was starting to experience depression. Other symptoms were starting to show up as well. I had a conversation with you about this, thinking, what other causes could there be? It sounds like what you just described as FND really did explain maybe some of what was going on with him. There's like a mismatch of the sensory and also how it's triggering a response in the muscles. How do people get to you? Is his story pretty common that maybe they would have been through several doctors before they find a clinic like yours?
Unfortunately, many people have a delay in diagnosis, often lasting years. Clinics like mine are pretty unusual. We started the first pediatric FND clinic in the country. We've been going for 8+ years now, and there are at many academic centers, they now have someone who does what we do. So it's becoming more and more, but still, folks have to travel a long ways and wait a long time to get help. One of the things that you described in his symptoms really caught my ear, which was that he's able to do it, but that he tires out more quickly. It becomes painful. And it's very similar to something I hear people who have FND say of their gait, of the way that they walk, in that a person can often make their legs do things. They can walk in a manner of speaking, but they're using a much less efficient way of walking. They've lost the automatic nature of movement. And that loss of automaticity is something that we see across a lot of different kinds of FND. Maybe muscle tension dysphonia might be the same thing. What we think is happening is that the brain's motor systems start off having to work through a process to complete a task, but then very quickly our brains just take it as an automatic that you don't have to think about every step, you just walk. You don't have to think about the way that you're placing your lips and tongue, you just speak. But when a person loses automaticity, they are using a less efficient version of those motor plans, so they tire more easily. They're not able to articulate or place their fine motor positions as precisely as they could before. So I think what you're describing would fit well with other types of FND we see.
So let's say a patient comes to you after lots of attempts to get help with the symptoms they're experiencing. What is the diagnosis process like for you?
So a person who has functional symptoms may have something else that is driving their functional symptoms. So we do our best to, number one, identify functional from other types of symptoms to try to understand, is this a person who has FND in isolation? Is this a person who actually has some other disorder that's a better explanation than FND? Or is it, some A leading to B, that yes, there's FND, but the real problem is this other symptom that needs treatment more than the FND. For example, there are some kids who have such terrible anxiety that it ends up manifesting as an FND. And you can definitely help them for the FND part, but until you treat the anxiety, you're just not going to get control of their functional symptoms. At its best, it really should be a pretty holistic, full person sort of assessment that also involves understanding the families that helped bring this child to this point, both for designing the best treatment for them, but also understanding what things about this family dynamic might have perpetuated the symptom, or what might we need to change to help recovery to happen faster.
That's really interesting. Is that a line you have to walk very carefully when you're saying what we're going on with the family dynamics? I imagine you have to be careful. You don't want to assign blame for what's happening. Can you talk a little bit more about that?
I think it's important to go even beyond that many people come to our clinics carrying a lot of blame, that they have been told that it was their fault, or they've been told that they're faking it. They've been told that it's all in their head. And that sort of old school thinking is common enough that we try to proactively unburden people from that from the beginning we say, some people have heard this. We want you to tell you that's not the case. Some people have been blamed for this and it's not your fault. So those sorts of empowering messages, I think, are really important at the beginning. People have a hard time approaching a diagnosis that they don't know much about, that they may not have heard from before, if half of their mind is in that sort of protective space of, is this person going to make me feel like the previous physicians made me feel?
You mentioned anxiety as being could be a contributing factor. On your team, then, once you move into, well, I guess even a part of assessment, are you working with other professionals as well? Are you working with psychologists, psychiatrists? Can you talk about the team that you have in place that would, once they get that diagnosis?
So I have a great partner in the clinic. She and I started it and have run it together. Her name is Allison Wilkinson Smith. She's a PhD neuropsychologist. And every patient who comes to our clinic gets testing with Allison. So we have a deep understanding of where they're coming from psychologically, both the child and the parent. And that really helps us to understand the best way to help them. That I can do a lot for diagnosis and medication management, but really understanding how this person came to us today. Allison is the expert for that. We do partner with some psychiatrists, with physical therapists, occupational therapists, and social workers. There's often, this really takes a multidisciplinary team approach. It's often the case that people need more than one type of specialist can handle. So being able to bring all of those people into one has been one of the reasons why our clinic has been successful.
How does the team work together? Like, let's say they have that initial meeting with you. They start to work with the neuropsychologist. Are you then as a team talking about these patients, seeing what's working and what isn't?
The day one visit is both with me and Dr. Wilkinson Smith. So we see every new patient together, and then they will split off to do the diagnostic testing and we'll come back. Those first visits then typically take anywhere from 2 to 4 hours. And, I'm not in the room that whole time, but it's coming in and out of that room. So they will be in clinic 2 to 4 hours. Once we make our initial assessment, if we decide that FND is the most likely explanation for this patient's symptoms, then the question is, what does this person need today? Sometimes that might be medication, but other times that might be purely like a talk therapy counseling. Sometimes that might be purely physical, just a physical therapy or occupational therapy. There are even some patients where we say, look, this is FND, but what you need is actually to manage your pain disorder or something else, because that's the primary driver of the functional symptoms. And I would say at least a quarter of the time we say to the person, look, this symptom is functional, but there's this other thing too. this is not just one thing, and we need to keep looking. We need to keep investigating. Maybe they need labs, maybe they just need time. But if there's a part of the assessment that is unfinished, that a question that is still remaining in your mind, seeing them quickly, maybe back in 2 to 3 months, and letting time, testing, evaluation tell you more of the story is a really important part of the process.
So you are trying out physical therapy. Do they get better if they've had physical therapy, or are things staying the same? Then you make adjustment to that treatment plan. But there's
That's
something else
true.
going on that
That's
is not.
true.
Is that
And
accurate?
getting the right kind of treatment too. So, for example, there was a great paper by Glenn Nielsen, who's a physical therapist in London, and they randomly assigned people to either an FND informed physical therapist, somebody who really knew their business, or just the next available physical therapist. And the differences in outcome were just shocking. I mean, it was like 17% got better with the regular, 70% got better with the FND informed person. Much, much better
Wow.
by having someone who really knew how to treat these people specifically. We know that's true in every other areas of medicine. I wouldn't want someone to come to me for their dental care. I know the barest amount about that. But this area of treatment of FND it's just as important to have somebody who really knows their business.
I'm curious to know how the training of these therapists is evolving as you are learning more. Are there programs that really specialize in training F&D, or is it something that right now, at least, these other professionals are learning just by virtue of working in the clinics?
It is the latter, and
Okay.
really it's the latter for every medical specialty. There's not a fellowship training program for F&D that I know of anywhere, um, despite the fact that every neurologist in every office across the country is seeing F&D. This is the second most common reason to come see a neurologist. This is more
Wow.
common than stroke, more common than seizures, and yet there aren't specific training programs for helping these people.
That's a huge number. I didn't
Yeah.
realize that. That's the second.
Second only to headache in terms of reasons to come see a neurologist.
Wow, that's
And for
incredible.
neurology subspecialty clinics, movement disorders like mine, but other types as well, FND makes up about 15% of all of the new patient visits.
Do you
So it's
think
just a huge number of people.
do you think that that number is going to increase as awareness of this and kind of the stigma of it is if people are educated about it?
It may be the case that our ability to diagnose quickly would go up. So we might see a number of patients rise because of that. That, of course, would be a good thing, not a bad thing. In that circumstance, an increase in the number of patients just means that patients who were symptomatic are getting the diagnosis. We know that times of conflict, times of increased social stress, those can be triggers for FND. So, for example, we wrote a paper a few years ago right after the Boston Marathon bombings and showed that pediatric FND peaked in the week after the bombings. Other instances like 9/11, the pandemic, there's been much academic ink written about the ways that FND increased after those. So any sort of large scale societal disruption is likely going to see an increase in FND.
You talked to me once about how part of maybe what would help with the work is other physicians who aren't specialized. Uh, they might recognize that this patient probably has F&D, but they're not telling their patients. I guess you covered this that, but why would they resist telling their patients that this is what they think is happening?
That's a really fundamental question. So I did what any academic would do. I wrote a paper about it. So we used a series of data sets from our own institution and from child neurologists around the country to try to ask, if you know it's FND, why wouldn't you say? And the largest answer was that people were just afraid of the reaction. They were afraid that they were going to, families or the patients would be mad at them, that there would be a difficult conversation. Um, the irony being that if you start with an assumption that someone is going to be a jerk to you, it's a self-fulfilling prophecy, and you can certainly be a jerk to them first. And I think that's a big reason why the interaction may not go so well. with FND. So when physicians know and don't say, like with so many areas of our interpersonal interaction, that knowledge, we think we're holding it in, but the other person can see it in our face. And if people can sense that there's something hidden, that just poisons the interaction. That leads people to lose trust very quickly. I think that's part of it. There are a small number of people who felt like that if they were neurologists and they used codes associated with psychiatry, that they would never get paid for it. But that's not a thing. That's absolutely just lore that people have heard, but is not true. We systematically looked at that too, and that's just not a thing that like physicians get paid for using these codes all the time, whether they're psychiatrists or ER physicians or pediatricians. So all of the reasons why people gave for not being willing to share the diagnosis fell apart once we actually looked at the data.
That's so interesting. The coding is something I wouldn't even have thought about. This was a question I had, and you've talked about it a little bit, but this idea of symptoms being occurring as a cluster of different types of symptoms. You mentioned anxiety. I would imagine things like chronic pain. You also mentioned gait. Do you see that patients tend to have many things going on? Or let's say your example of anxiety, it's manifesting in gait. Are there other types of conditions that you see that kind of travel alongside FND?
There are many different forms of FND, and FND can take on the symptoms of almost any neurological disorder. There are functional seizure disorders. I mentioned functional gait disorders, functional movement disorders. One of the most common ways it shows up in emergency rooms as people who look as though they've had a stroke, and it turns out that it's actually functional. And of course, in that heightened situation, you do everything you need to do to evaluate and make sure that it is or is not a stroke. You go through all the motions, and then in the end, you find that it's actually FND. The dynamic of FND is often that a person will come to you with one symptom, but then quickly, within weeks or months, it will shift to something very different, something that would not be the case for other causes of neurological symptoms. And so that pattern of rapid shifting from one type of symptom to another is one of the clues that you're actually looking at FND. That's not a sign that it's not neurological. That's a sign that it's this specific type of neurological disorder.
Oh, that's fascinating. And I think that the conversation about the patient that I was seeing is what sparked me wanting to talk to you about this. Is he was talking to me, you kind of peel back the onion. How did this maybe start? Was especially with muscle tension dysphonia, it could be secondary, right? Maybe he had an upper respiratory infection, was trying to control a tickle that he was feeling, and so developed these compensatory habits that actually aren't very helpful for the voice long term. Right. And you go back and you try to figure out, okay, it was maybe that. Sometimes it's a perfect storm of things. He had that going on, also an incredible amount of stress at work at that time. Other things going on physically, managing weight, all of these things that were happening. And then him noticing, oh, my voice is not right. Nothing I do makes it better. And then catastrophizing around that, like I will never be better. Also, I have these other symptoms, like a pelvic floor issue. And if I focus on the pelvic floor issue, I notice my voice gets better. If I'm focusing on my voice, the other symptoms get better. Yeah. So it seemed to me to also be the severity of his symptoms were a result of where he's focusing.
Absolutely.
Is that something that you see too? How do you deal with that?
So Jenni, that's a great insight. And that aspect of attention is really important with FND. We know that that a person who has FND seems to be wired to attend to their body's symptoms more so than other people who don't develop FND. And that's true whether the person has FND at the moment or not. So there seems to be a greater awareness of the body's little tickles and twitches that all of us have as just part of being human. Well, the person with FND notices more of those things, is more aware of, say, heart rate variation or abdominal movement in a way that all of us have, but most of us, it kind of just goes under the radar. So I wonder if, as he was noticing his speech changing and his attention to that speech change became more and more, that actually made the problem worse and worse.
That's part of the problem with therapy for that is if I'm giving him more exercises
Yeah.
to do to help release tension here, to help typically what would help with unloading some of that tension and make it better is he would find he was more discouraged about his voice because
Yeah.
when he paid more attention to it, yes, the symptoms would sometimes get worse.
Yeah.
And what I started doing was it was shifting the exercises I would give him. So instead of focusing here, we would focus on breath. So
Hmm.
instead of being concerned about pain and discomfort, when I gave him exercises to address that, they
Hmm.
would sometimes get worse. We shifted to, okay, well, let's focus on an area that doesn't seem to be impacted with symptoms of pain or
Hmm.
fatigue. Let's focus on breath. We'll focus on the movement in the belly. And that did seem to help. And also focusing on, I had him start journaling positive experiences with the voice. And what he started to discover was, wow, actually, I have a lot more good days than I have bad days.
Yeah.
But I get so attuned to the bad days
Right.
that it's hard to recognize the good days.
So it's a sign of a good therapist.
Uh,
You have intuited something that is talked about among the physical therapists and occupational therapists I work with, that oftentimes if a person has, say, a functional gait disorder, you cannot just push them, you cannot just do the strengthening exercises that you would with another patient. You have to work around the disability and say, well, I know that your right leg isn't going to work great. Let's just focus on the left leg. Let's just work on balance. All the things that you were describing with voice, that's the same thing our physical therapy colleagues do. And my strong suspicion, and this is more intuition than it is science, but this is the loss of automaticity. That as you pay more and more attention to exactly how you do a movement, you lose the ability to make the smooth and coordinated, highly efficient movement that your brain already knows how to do. So you get in your own way. That's the fundamental mechanism of FND, in my opinion, is that you're getting in your own way.
Gosh, how do you get out of your own way?
Yeah.
That's the $1 million question.
So often getting a person back into the things of life that engross them, that they really enjoy, that are important for thriving, those things are also helpful for F&D. So in the case of kids, getting them back to in-person school is often part of it. If they have lost the ability to do the fun after school activity that they enjoyed so much, finding a way to get them back to some of it. Maybe you can't do dance team the way you did before, but you can go to practice. You can review routines, even if you can't be on the floor. There's just so many ways that you can substitute in, and that's a way of getting back to the exercises that you couldn't do. And it doesn't come straight away, but the person builds back to it.
How long are your patients in treatment?
It depends a lot on the nature of their F&D. For some people, anxiety is such a trigger that if you can get better control of their anxiety, their F&D will substantially improve or melt away even. So sometimes that could be a medication, sometimes that could be just counseling, sometimes it's a combination of those two. For people who have purely a movement-related F&D, especially something like lower extremity weakness, there you can make very quick improvements if the person is able to recover that automaticity. So I have had people come to clinic not having walked for weeks, and then they walk out of clinic. So it can be a very quick
Wow.
recovery, like literally within minutes, but that's the exception, not the rule. Most people require some getting back to it, but it can be very rapid.
So your patients sounds like the biggest benefit is there's hope.
Hope's a huge thing. Yeah.
There's hope that maybe, well, let me ask you this. Are they cured? Is there a risk of recurrence?
There's a risk of recurrence, and I always tell people the longer you go without an F&D episode, the more stable your recovery is. But you're always going to be somebody who might fall back into it. But at least in childhood onset F&D, the likelihood of outgrowing it is much better. Adult F&D tends to be stickier. It has a lower recovery rate. We don't know why that is. We don't know whether that's a fundamental neurobiology difference or a difference between being embedded within a family versus being on your own, or a person who can exit from responsibility for a while and it's okay versus having a job and responsibilities. We don't know which of those or which combination of those it is, but kids do better than adults.
Sorry, my brain is running a million miles an hour. I'm wondering too if
with my patient again as an example, there are those pressures of work, right? I'm having a symptom show up in my voice, but I have to have my voice work for my job.
Yeah.
Is there always that fear that, oh no, it's coming back?
Yeah.
So as you said, the attention issue becomes, I have to pay attention to it a little bit to make sure it doesn't come back. But by focusing on it at all, you might be setting yourself up for a
Yeah.
recurrence.
And for that sort of thing, I think working with a counselor to specifically to develop a specific plan is very helpful. So if you know that a given circumstance is your most common trigger, or maybe just the thing that you worry the most about triggering, then you develop a behavioral strategy around that. When I get to school in the morning, or when the meeting is about to start, here are the steps I go through. And just having a process to go through really helps people to get through the initial rough patch.
So some kind of checklist you go through, you build this pattern, this habit that you know if I go through this, I'm going to be okay. I'm going to get through the meeting consistently.
Yeah. And you used the word catastrophizing before. And I think that's an accurate way to describe it. That if you can even help a person to not let that little tumble of rocks turn into an avalanche, then that can be hugely effective. Like it's okay to be worried, afraid a little, but what's not okay is letting it turn into this huge physical response. So breaking that chain is one of the things you work on in therapy.
One of the things that I try to talk to my guests about is how tied up something like voice, how tied up it is with your identity. And I recently had a conversation with Dr. Leslie Childs from UT Southwestern Center for Voice about there being a period of grief when there's a loss of function. Now, you may very well get that function back, but that there is this period of mourning or grief. What's interesting about what you do is it sounds like it's almost a relief when they get to you. Maybe they've gone through some grief, but now there's a hope that so many people have made me feel like I'm making this up, or so many people have made me feel like this isn't real.
Yeah.
They come to you and there's a relief that someone's listening, someone believes them.
That's what we're going for, at least. We're not successful every time, but that's what we're going for, is that people know that we're going to do our best to try to figure them out. We're going to do whatever we can to help them. And at the very minimum, we're going to hear them. We're going to let them tell their story. And that's one of the reasons why our visits are so much longer than most clinic visits, is that people often just need to get the whole thing out to feel like you know really what's going on. Like it's often the circumstance that just from reading the notes, I'm suspicious that a person's symptoms might be FND. You know, that you don't make a diagnosis based on your first impressions, but you at least have a first idea. But a person may need to get through it all to feel like they can trust you to believe that diagnosis.
I bet that is huge, that trust element.
Yeah.
What kind of educational opportunities do you take advantage of, or awareness building activities, I guess I should say? Is there outreach that you do with doctors in the area? How do you get the word out?
Yeah, so there's a great organization called the Functional Neurological Disorder Society that we started it just a few years ago. I'm a founding member, and we have an annual meeting. I'm sorry, a meeting every 2 years to bring together all the people around the world that are really interested in improving care for FND. There are several family organizations and patient support groups. One is called fndhope.org. That's a great one. There are several people who have started FND specific counseling practices for teens. There's one local in the DFW area, and there's one online that I know of, both of whom patients have had good results with. I do education efforts at universities and at continuing education, things for physical therapy, physical medicine, and rehabilitation, rehab doctors, and for neurology grand rounds. So anybody who invites, I'm happy to come talk about FND. I should also say that there have been FND clinic days where every single person who is referred to us for FND turned out to have something different. That it is just as important that I say this is not FND as it is that I affirm somebody who truly has that diagnosis. Really trying to maintain a neutral stance of maybe it's FND, maybe it's not. We got to do a careful evaluation. It's a really important part of it.
So I would imagine sometimes people would look at FND and think, oh, it's a diagnosis of ruling
Exclusion.
out of exclusion. Thank you.
Yeah,
If
that
we've ruled out everything else, it must be this.
right.
But what you're seeing is maybe there's something underlying that was missed along the way.
There's a saying in medicine that the 10th doctor is always the smartest.
Oh, right.
But sometimes you're the 10th and sometimes you're the first. So with time and exposure and like things tend to become evident. So maybe it's just a simple matter of time that things become more clear. But um, the idea that FND is a diagnosis of exclusion is an old idea, but an idea that has been fully put to rest. We know that that is just not the case. That the rule book for making diagnoses, mental health diagnoses, is called the DSM, the Diagnostic and Statistical Manual. And it used to be that the DSM had language about excluding other causes in the diagnosis of FND. That's no longer in the book. That's not part of the rules. You don't have to exclude every other possible thing. More important than just the rule book, though, I think that people need to think through the way that they frame their search about whether they're looking for positive features versus trying to exclude everything else. Because in truth, FND has very specific features that the sound of muscle tension dysphonia is unlike most other causes of dysphonia. The types of functional movement disorder that I see look very different than other causes of movement disorder. It's not at all a negative. We're recognizing positive features, and that allows you to just tell the patient what you're seeing. Not, I think it might be FND, but I have to do all this other testing to confirm that it's not the things I already know it's not. That just doesn't make any sense.
Where do you think, because you're not only practicing, you're also doing a lot of the research into this area, where do you see FND heading? And what are the areas of research that you're most interested in?
For a person who has severe and refractory FND, maybe they've
What
gone
does that
years.
mean?
Refractory means it doesn't get better, resistant to treatment. So for that person, my hope is that someday there could be direct interventions. So the idea of doing something like a brain surgery is a dramatic thing for any sort of medical symptom. But the idea that we would do brain surgery for something like FND is a shocking initial thought. But when we look at the levels of disability that a person with FND has, they are just as bad as a person who has terrible Parkinson disease or terrible epilepsy. It's just as disabling as those other disorders. So that is something that would be way down the future. That's not on people's radar at the moment. But if there was a way to help a person with FND with something like an invasive treatment, there are people who are so disabled that it might be worth it. So perhaps something along those lines. Having better access to inpatient therapies would be hugely helpful. It's often the case that a child will come to us having been out of school for months. Parents have been out of work for months because they have to stay home and take care of their child because of their FND. And we try to make the case for an inpatient admission for aggressive psychiatric and physical therapy, and they just won't take them. That the insurances will block that. So that's a huge frustration. So we're often putting together a plan that we can actually put in place, not the ideal plan.
Is there a day program?
So our hospital has a psychiatric day program. We also have an inpatient rehabilitation program that can be useful for FND, but for other things as well. And there are several programs around the country that do take kids as inpatient hospitalizations. One of the things that is a little tough about FND relative to other two disorders that are purely in the mental health realm is that psychiatric care facilities are set up to help people who have depression, anxiety, schizophrenia, psychosis, things that are mental health. If a person has a physical manifestation, oftentimes the psychiatric hospital is just not really set up for that. So if a person's FND symptoms are that they can't walk, like the psychiatric hospital doesn't have a checkbox for that. It's not part of the way that they do their care. So having facilities that are comfortable with both, that would be the ideal. That's what we would love to build. We just don't have it yet.
It's so fascinating. And I hope you will share some of the links to the studies that you've been a part of. I would love to be able to post those in the show notes and just kind of share a little bit more knowledge about
Sure.
this, what you do. And Maybe we'll find some huge big donor who'll be like, yeah, I'm going to build you a new center and you can do with it what you want.
I would be first in line.
Is there any other aspect of this that we didn't cover, or something that you really wish families at home would understand about FND?
Yeah, I wish that people could see the optimism that we have, that many people do get better, and that this is one of the reasons why I have come to love FND, is that I can help people in ways that I often can't help them if their symptoms are a genetic disorder or a neurodegenerative disorder. Like there's so much benefit for the healthcare provider in treating FND, because like you get the jolt of good emotions in a way that is more powerful than just about anything else. So it is great to be an FND physician because the patients are awesome, the stories are so great, and you get people better in a way that is hard with other diseases.
Oh, what a great closing thought. You bring hope, and then you experience the joy
Yeah.
of the recovery, of the hope. Ah, Jeff, you were just so smart. It's so great to get to talk to you. Thank you so much for your time today.
Thanks so much for joining me on Speaking of Talking. If you loved this episode, I'd be so grateful if you'd leave a review, share it with a friend, or send it to someone who geeks out on voice just as much as we do. For more tips, tools, and behind-the-scenes goodies, head to the show notes or visit us at jennistack.com. I'm Jenni Stack. And remember, your voice isn't just how you sound, it's how you show up. Own it, trust it. And let's keep talking, because we've got a lot to say.